Hi everybody, my name is Francis Andrews. I'm the Medical Director for Bolton NHS Foundation Trust and I'm also a consultant in the emergency department. Delirium is defined as an acute confusional state which is usually due to medical causes. Now, it's very important because you need to remember it's a medical emergency because untreated it leads to an increased morbidity and mortality. The death rate from delirium is, believe it or not, higher than from heart attacks and strokes. And 1 in 5 patients who are admitted acutely have delirium, so it's very common. We in Bolton have recently redesigned delirium screening in the emergency department, which is one of the busiest A&E departments in the Northwest. The following video will explain what happens currently at Bolton Hospital and how we do a delirium screening.
My name is Emma Pickavance, I'm a consultant geriatrician. The 4AT is a really simple delirium screening tool. It takes less than a minute to do and it's really sensitive and specific to pick up delirium in your patients. There's no specific training required. The more you use it, the better you'll become at it in picking up delirium in your patient group.
I'm Dr. Kalat, one of the consultant physicians in elderly medicine. There are 3 types of delirium which one needs to recognize. First type is hyperactive delirium, and patients are usually quite restless, agitated. They might have problems with sleeping, they have reversal of sleep patterns, and they could be quite wandersome. The second type is hypoactive delirium, and they are very withdrawn, drowsy, and somnolent. They don't engage with staff and communication or with medical interventions. And the third type of delirium is mixed, alternating between hyperactive and hypoactive delirium. Patients who have hypoactive delirium often go unrecognized, and unfortunately this type of delirium is associated with poorer outcomes. So it's important for all of us to recognize delirium earlier on during the hospital admission and classify which type if possible.
Hi, my name's Dr. Louisa Jackson. I'm one of the consultant geriatricians here at Bolton. I want to talk to you today about some of the causes of delirium, and I think the key points to take away are that there are really simple things that we can do to improve delirium care for our patients here in hospital. I'm sure all of you have heard of the Pinch Me acronym, and I'm just going to talk you through that today. So P is for pain. I think this can often be quite difficult to assess in some of our patients who are older and frailer with cognitive impairment, but it's always something to consider and ensure that they have adequate analgesia on board. I is for infection or intracerebral causes. So making sure that we're looking for any evidence of infection and doing that appropriately, so avoiding unnecessary tests that we know are not particularly accurate, including urine dipsticks. And also considering whether we need to think about any intracerebral causes. I'll do a CT, for example. N is for nutrition. So this is recognising in our patients how we can help with nutrition in a hospital environment, ensuring that they have adequate access to food and fluid, even in our A&E departments, for example. C is for constipation. I think one of the important things to think about here is both bladder and bowel. We recognise that constipation can be a cause in itself of delirium, so making sure that we take a proper history and examination and thinking about laxatives. Thinking about bladder causes, so thinking about things like urinary retention as a cause for delirium as well, thinking about whether we might need to do a bladder scan in that situation. H is for hydration and hypoxia. Again, that's thinking about how we can maintain adequate hydration for our patients, offering them a drink, ensuring that they have easy access to food and fluids, thinking about whether they need supplementary hydration in terms of IV fluids, and obviously hypoxia in terms of looking at their oxygen saturations, making sure that they don't need any supplementary oxygen. M is one of our favourites as geriatricians, and that's medications. So there are numerous medications that can be delirium inducing. And I think one of the important things that we all practice is when we're seeing any patient, reviewing their medications, making sure that the medications that they are on are appropriate and are not causing any undue harm. And then E is for environment, and that's always a real challenge in hospital, especially at the moment, but making sure that we think about inappropriate ward moves, trying to ensure that places are safe and that things like lighting and noise are minimised as much as possible. So that's a quick run through of Pinch Me, and I think, as I say, it's something that we can all do on small scale that can have a big impact on our patients.
Hello, my name is David Nielsen. I am the Admiral Nurse, the Dementia Specialist Nurse for Bolton Foundation Trust. Management of delirium is very simple. You have to treat the cause. Prevention is also very important to reverse delirium. Delirium measures rely on orientation of the patient, addressing sensory impairments, making sure that their glasses, hearing aids are on and functional, and looking at their nutrition and hydration, ruling out dehydration and malnutrition. Ward moves, especially at night, can be very traumatic for a patient and family, especially if they have a delirium, and it could lead to worsening delirium and with grave consequences. Falls, aspirations, immobility, aggression and agitation, and can also lead to pressure sores. Remember, the management of delirium needs an MDT multidisciplinary team approach.
So my name is Dr. Gopal. I'm a consultant geriatrician at the Royal Bolton Hospital and also the clinical lead for delirium at Bolton. In this video, we've seen the different tools for delirium screening and management. So we've seen something about the SQUID, a single question for delirium, the 4AT, the most valid tool for delirium detection, the time bundle going through the causes and investigations for delirium. I hope you all find it very easy to use and start using it so we can manage delirium more effectively. The last thing is about what to do in delirium. So think delirium if somebody is acutely confused, and once you think delirium, call it a delirium, and once you call it delirium, think about doing the SQUID and the 4AT. The things not to do in delirium: don't forget about hypoactive delirium. The mortality is way worse than hyperactive delirium. Please avoid moving the patient in the middle of the night, even if it's absolutely necessary. This can be way worse for the patient and the family. And please don't try and use medications to calm people down. This has got way more side effects. Please use medications only if the patient is a danger to themselves or other people. Thank you.